So let's start the Neonatal Resuscitation Program video. So all the questions I'll be telling you in this video are the table viva questions which you should be thorough. Okay. So your NRP begins with the 4 pre-delivery questions. So what are those 4 pre-delivery questions that you will ask from your ops team? So the 4 important question is, what is a gestational age? Is the amniotic fluid meconium stained? Are there any additional risk factors? Or what is the umbilical cord management plan? So if the answer to all the 4 questions is like the gestational age is term, there is no meconium stained amniotic fluid, there are no additional risk factor, the mother is not GDM, not hypertensive, no other factor is there. So your umbilical cord management plan is to delay cord clamp. Okay. That's what you'll plan, that you do not need any excessive resuscitation for the baby. You are expecting a normal outcome. So your umbilical management plan is to delay the cord clamping. But if there is any risk factor, if the baby is preterm, there are twin delivery, the amniotic fluid is meconium stained, there are other risk factors, the mother is obese, the mother is anemic, or multiple risk factors, the mother has preeclampsia, GDM, then you need a team. For every delivery, we need at least one qualified individual. Every delivery, regardless of the risk factors. So one individual we need for every delivery, but if there are risk factors present, we need at least 2 people to manage the baby. There should be at least 2 people to manage if there are risk factors. However, you will learn further that we actually need a team, not just 2 persons. We actually be needing a team, one to put the saturation probe, one to do the documentation and all. So that I'll be telling you later. So you just need to know this right now, that if there are no risk factor, you need one qualified person. But if there are multiple risk factors involved, then you need at least 2 qualified individuals. The team that is being ready for the high risk delivery should have a team leader. So we need to identify who is the team leader amongst us. Then we will perform a pre-resuscitation team briefing. That is, the elected team leader will define roles, that I will do the airway, you manage the heart, you will put the probe, and you will document everything. So the team leader designates task. Also at that time we will perform a quick equipment check at that time. So after doing all that, every resuscitation needs to have a team leader. And who can be a team leader? Any member who has mastery of the NRP algorithm and effective leadership skill can be a team leader. So if the question says a nurse, a neonatology nurse who's experienced in NRP, can she be a team leader? Yes, the answer is yes, she can be a team leader if she has experience of NRP, she has effective communication, she can manage the team well, she can be the team leader. It does not have to be confined to a doctor. Anyone can be a team leader who has mastery of the NRP with a good communication skill and a leadership skill. So let's come to the whole NRP algorithm. So now your NRP starts. You have asked the 4 questions. The 4 questions says there is no risk factor. You have you are the individual, sole individual if there is no risk factor. You are a team if there are risk factor. So what you will do? You will start with the antenatal counseling here. That is, you need to tell that the delivery that we are expecting here is a high risk delivery. You will speak to the parents and tell them everything, that what you are expecting. If it's a prematurity, if it's a 28-week baby, you will tell the parents that you expect that the baby will be staying in the NICU for at least 2 months, and you will start with the head to toe counseling, that there can be chances of PDA, NEC. In your own words you will tell them. Now comes team briefing. So now the NRP starts. After entering the LR or OT, you will do 3 things: the antenatal counseling, the team briefing, and the equipment check. Now, when you are asked about equipment check, you will be told how will you check the equipments. So please don't tell that you will check the laryngoscope, you will check the ET, you will check the resuscitation tray. No, you do not have to answer it like that. There is a specified order the NRP has mentioned that you will have to check so that you do not miss anything. It starts with warmth. If you open the NRP PDF, you will get to know that they have very clearly started with the problems that a baby faces, and accordingly they have arranged the instruments. For example, you want to prevent the hypothermia, you want to manage the temperature of the baby, so it starts with warmth. You will check the preheated radiant warmer. You will check whether there are towels or the blankets present. You will check if the temperature sensor is working, and you will check that there is hat to cover the baby. What's important here is a plastic wrap. If the baby's gestation is less than 32, you will ensure that there is a plastic wrap or a cling wrap to cover the baby, because we won't be drying the baby less than 32 weeks of gestation. We'll be directly covering them in the plastic wrap. Why is it done so? It is done to prevent the evaporative heat loss. Okay. Now, you also need to arrange a thermal mattress if the gestation is less than 32. Okay. So now, after all that, for warmth, you will say all these things. For clearing the airway, you will ensure there is a bulb syringe, there is a tracheal aspirator, there is a stethoscope available. So you will ensure all that, or that all these are present. Then for ventilation, you will see the flow meter is working, there is an oxygen blender, there is a preterm size mask, there is a cardiac monitor. All this you will ensure. For intubation, you will see if there is a stillet, there is a positive pressure ventilation device, a pulse oximeter, endotracheal tubes. So please answer in this order. For medication, you will check that you have the epinephrine ready, the ADR ready, and then might be needing to put a UVC. So if you should be having a UVC catheter, all that you will ensure. So answer in this order only. That when I'll enter the room, I'll do the team counseling, the team briefing, the equipment check. How will you check the equipments? I will check the equipments in the order. For warmth, I'll ensure the radiant warmer is working. For oxygen, for ventilation, I'll ensure there is a blender. So please answer in this order. So now, after that you have ensured, then comes next. So what is important here? Sorry, this is badly highlighted, but you need to see this. After the baby is born, after you have done all this and the baby is born, you need to ensure. So if the baby is a term gestation with good tone and the baby is breathing and crying, I will give the baby to the mother for a skin to skin contact and early initiation of breastfeeding. That you will do after you have ensured that you have done the initial steps. That is, you have dried the baby, you have covered the baby adequately, and you have given the baby for a skin to skin contact to the mother. And you have to answer that I will continue with my ongoing evaluation. So what is ongoing evaluation? They will ask. Ongoing evaluation is that you will continue to monitor the baby. That you will just see that there is nothing like the baby is transitioning well. You will continue to monitor for every 2 hourly. Alright. So if the answer to above questions like term, good tone, and breathing or crying is no, then we'll start with warm, dry, stimulate position. WDSP, just remember that. You will start with the warm, dry, stimulate position. These are the initial steps that you will do. And if you find secretions, then you will do the suction. That if needed, you will do the suction. So even after that, you have done that, and now you see the baby is apneic. The baby is apneic, gasping, or the heart rate is less than 100. Means after you do warm, dry, stimulate position, you will auscultate, and if you are auscultating and you see the heart rate is less than 100, or if you find the baby is apneic or gasping, then you will start with the positive pressure ventilation. So the question comes, what is the indication for positive pressure ventilation? So remember, there are 3 indications. If the baby is apneic, the baby is gasping, or the heart rate is less than 100. So you will start positive pressure ventilation. You will ask your assistant to put up pulse oximeter at this point. in the right arm, you will ask your assistant to do that. And you can consider a cardiac monitor, that you can consider putting up a ECG. Very important thing that you should be remembering now. So if you're a single person, you will call someone for help at the time of positive pressure ventilation. So indications of positive pressure ventilation, I told you just now. You will tell the 3 indication if the baby is apneic, gasping, or the heart rate is less than 100. So positive pressure ventilation is the most important step in neonatal resuscitation. Please remember that 99% of the apneic baby can be revived through positive pressure ventilation if you have started within the 1 minute, which is known as the first golden minute. So how can you give positive pressure ventilation? Positive pressure means you are giving pressure from outside. You are giving pressure to open the lungs. So it's positive pressure ventilation. You can give positive T-piece resuscitator, a self-inflating bag, that is the ambu bag, and a flow-inflating bag. The anesthetist people use this. Alright, you must have seen this. The problem with all of these that T-piece resuscitator requires a compressed gas source, so is the flow inflating bag. But ambu bag, we do not need a compressed gas source. For positive pressure ventilation, we prefer 1 and 3, that is T-piece resuscitator and a flow inflating bag. Why? Because they give a measured pressure. You know the pressure is set. You have set a limit, and they will give the pressure according to that only. Your assistant, who is after putting the saturation probe in the right arm, will now auscultate the heart while you give positive pressure ventilation. So after 15 seconds of positive pressure ventilation, you will ask her, is the heart rate increasing? So she will say yes, it's increasing. Then well and good, you will continue. But if she says no, the heart rate is not increasing, then what you need to do? You will ask her, is the chest moving? The next important question is if the chest is moving or not. She says no, the chest is not moving. Then you have to do the ventilation corrective step, which is MR SOPA. The ventilation corrective steps is only to be done when the heart rate is not increasing and the chest is also not moving. So what it involves? It involves MR. You will do MR, that is mask reposition and airway reposition. You will align the airway, you will do mask reposition. Then give 5 breaths. Ask her again, if the chest is moving now. She said no, the chest is not moving. Then you will do suction and open mouth, SO. This is to be done in this order only. You will suction the mouth, you will open the mouth, and then give 5 breaths through positive pressure ventilator. Then you will ask her again, and now she says no, the chest is still not moving. Then what to do? Then we'll increase the pressure. And the maximum pressure, you will be asked this question, what is the maximum pressure? For a preterm, it is 30 mmHg. For a term, you can go to 40 mmHg. So this is the part 1 of the video. We have covered MR SOPA. P we have covered, we have given till pressure. I'll be doing the part 2 of this video soon. So stay tuned. Thank you so much.